The question now is that the words proposed to be omitted stand part of the question. I call the member for Bowman.
Deputy Speaker, the problem is that we all think we've got time, as Cornfield said. But in healthcare, that's not the case. It's been too long waiting for solutions to the flawed and vexed challenges in the Australian health system. We know well that we have schisms running through both between federal and state provision, between private and public, and between after hours and working hours care. But this legislation takes us no closer to solutions to those areas. I guess today is an appeal both to the other side of the chamber on behalf of Australians in every corner of this country who ask the question, what's actually happening and what's changing? And it possibly reflects an overwhelming and pervading fixation of the other side of this chamber on the shell and pea game of fiddling with financial systems, but actually not getting down and working out what's going to deliver a better health system. And it seems good to have a national framework, and it seems great to have local networks, and it seems great to have a Commonwealth government that is omniscient and able to make decisions from right here in Canberra about the community and public health provision in every corner of this great land. But in reality, we know that this long tension that's existed for 100 years between the federalism of devolving responsibilities down to local communities and the other argument that we centralise to try and make sure that those decisions are as perfect as possible has never really got us any closer to improving our health system. What has changed it are revolutionary ideas about how we engage communities' health from a hospital. We need to step away from that notion that people inside a hospital are so fixated on acute care that they can't think about community care. This notion that because you work in a hospital you don't understand what it's like outside the hospital. We need to understand that our clinical staff are the people and our researchers are the people who think about community and public and preventative health every moment of their waking lives and involve them in that process. So when this Labor government had a moment to think about how we would fix the challenges of the health system, and they had the audacity to set a date, I think everyone was struck by the challenge that they could actually get somewhere. But in fact what we've seen is that nothing happened by that date. We now have a new Prime Minister rolling out the same old bureaucratic changes, almost a reflection of their own impotence, that they can't get down and sort out public and community health. Now, it's one thing to believe that if we take the money from one pot, put it into a bigger pot and reassign it back to where it was in the first place, that somehow things will be better. And I don't mean to demean or diminish the very hard work that's been done in drafting these changes, but I beg of every person listening to this debate, ask yourself, how will the public health provision in my community be different? How will it be improved? Because here we are in 2010 waving goodbye to another year of a Labor administration. And it's this side of the chamber that has to ask that very important question. What has changed? Because you can't keep putting off what should have been done the day before yesterday until the day after tomorrow, because ultimately the things that were easy become hard and the things that are hard become impossible. And we need to join together as a nation and say, taking over 100% of community funding and assigning it to the Commonwealth sounds seductive. But in reality, this is a job that is done by communities, that is tailored to Indigenous communities, to mining communities, to rural communities. And the case that needs to be made on the other side is that Canberra can do that. The case hasn't yet been made. The case has not been yet made that the states are failing in that role for any other reason than VHI, that they are not adequately funded to do the job. Sure, we all collect the GST and then it is reassigned after it's run through a Commonwealth Grants Commission process. But there are no longer adequate partnerships between Commonwealth and state. And these national partnership arrangements that are $1 billion here and there simply haven't done the job. Now, before government members get too excited about the increased amounts in healthcare, let's just add them all up. And in 09-010, that amount was $12.074 billion, and next year it goes to $14.74 billion. And unadjusted, that's just under 20% increase. Now, that's what used to happen under the old hospital arrangements, the old 4-year funding agreements, unadjusted increases of between 17 and 26%. I commend the government for increasing health funding, but that's what every government's always done all of the time. Now, some governments will increase it higher in some years than others, but it is no more legitimate to say that we rip funding out of the health system than it is to say that the Labor government rips funding out of the school halls program because you spent it all last year and not this year. It's silly economics, because there are times when more money goes into health and other times when less. Obviously, this was a coalition government that had to pay off a massive Labor debt, so we focused on doing that for very good reasons. When it comes to funding hospitals, both sides of this chamber can lay claim to good and bad. But while this government is in power, we need to ask, what have you done this year? What has been done last year? And the great frustration to many is that we just keep having these administrative bills brought to this place, where we dream that perhaps by setting up an independent funding authority and then a performance authority and then a health and hospital fund and then local networks, that in some cases things that in any way things will be any better. That case has not been made by the government. I know that they are seduced by the notion of large, nationwide corporate structures that are controlled out of Canberra. But look, let's be honest. We've had a situation where we ran down the power of school principals, of hospital superintendents, and it was centralised to either district offices or state governments. We've had a system where slowly we've eked power out of state bureaucracies to deliver services and centralised them here to Canberra. And then we've had Canberra bureaucracies having power stripped away from them and centralised in ministers' offices. And we've had Labor ministers who complain they can't get in through the Prime Minister's door because all decision-making resides there. And eventually it is just an intellectual constipation because we are waiting for an omnipotent Prime Minister to make decisions like some sort of communist decree that comes out of China or Soviet Russia. What we need is to trust local clinicians. And all we asked of the other side of this place was that we involve ordinary, everyday folk in hospital boards, particularly in New South Wales and Queensland, where we know that these hospitals and their decision-making have basically drawn away like an outgoing tide from the local population. So they turn up and they can't get into emergency, and they wait on waiting lists that never ever materialise into an operation, and they just want to know why. They know a lot of money spent in health, but they don't understand how. And I'm not going to stand here and just say to you we need to slash the health bureaucracy. I'm not going to say we've got frontline staff that aren't performing clinical services, therefore they need to be done away with. No, that's overly simplistic. What we need to know is that leading figures in each community can be part of a hospital board. Now, of course, we need to resolve the issue of whether these hospital boards actually run the hospitals or simply monitor them. And the role of a hospital board fundamentally is to be a conduit for passing information between the decisions that a hospital makes and the community that is affected by them. And that is utterly legitimate. And the criticism from Queensland Labor was that we have the butcher baker and the candlestick maker on the hospital board and that they can't possibly run a hospital. But they are ordinary, everyday people who have a grasp of what it takes to serve and a grasp of what it takes to deliver health care. And that's why we do need to incorporate these skills, people who are not necessarily health professionals, in listening to how health decisions are being made. That was the simple request by this side of the chamber. How the Labor government responded was fascinating because they simply said, well, we will allow local decisions to be made as well. But they're made by $570 million of extra bureaucracy in a fourth layer of government that obviously controls the health system. So we still have this curious situation where the Commonwealth is involved in immunisation services, the state governments are involved in delivering immunisation services, local jurisdictions and city councils deliver immunisation, and now thanks to Mr Rudd and now Mrs Gillard, we have a fourth level of administration running our hospital system, but worst of all, it's a fourth level we can't vote out. Worst of all, it's a fourth level that has no accountability to ordinary Australians. Worst of all, it's a fourth level that we have to blame in this post-Rudd environment, Deputy Speaker, where everyone is responsible for everything. And the last thing that we need is a situation where you don't know who is not performing. The great attraction of clearing up this complex miasma of health decision-making in Australia is to determine who delivers services most effectively and let them get on with competing to be a provider. But we remain, after all of these reforms, Deputy Speaker, with a health system that has this curious bipartite purchaser arrangement and a single public provider that doesn't work with the private system. We still have a public system, Deputy Speaker, where the faster they work, the quicker they go broke, and a private system where the faster they work, the richer they get. And that challenge has to be resolved. It's a nexus that we simply haven't even begun to scratch the surface. Now, the solutions are right in front of us, but it's a government that is not looking. and you only need to go and see the complex cancer services or the eye surgery that is being delivered through the private means, through private providers, through streamlined systems at a fraction of the price with 100% outcomes. I'm just asking this side of the chamber, why don't we learn about how those cancer services are delivered? And let me throw a complex notion over to that side of the House. Please accept it. And that is that potentially the private system may do parts of our health work better than a public system will ever do. Let's also face the fact that public services may well remain more efficient and more effective than private services ever can be. So why don't we engage in a partnership to work out how that's best done? Why don't public hospitals accept that there are some things that they simply cannot do as well? Why don't we reach out across that fiscal divide and involve private services as a competing entity in providing? It's a simple challenge. Because, let's face it, they are the reasons why people in my community of Redlands can't get to see a doctor, wait for hours in casualty, sit on waiting lists for operations that will never come, and of course, end up in medical wards taking up valuable acute bed space. I put a simple challenge to the government. What are they doing for aged care provision, for the wages of our aged care nurses, for the infrastructure costs of building aged care facilities? There's been almost no movement on that in 4 years. But it's an integral part of a functioning health system is to return people who are discharged to the community. I set the challenge to the government. What is happening with transitional care? What is happening to engage the private sector? What is happening to connect hospitals with community health care? It's one thing to say the federal government should be running private and community and public health. So what does that leave the states? Completely unengaged in the process. The last thing that you want is the jurisdiction paying 40% of the hospital bills having no interest in community health. A much simpler way would have been to have a dollar-for-dollar national partnership arrangement on this very question and keep all 8 jurisdictions in the room on community health. But no, this government has lost 7 of them and will go it alone providing community health. The greatest mistake of the legislation we debate today is that 7 jurisdictions walk away from community, preventative and public health and are no longer engaged. And that's a great loss. Look, we all know the situation of current funding arrangements and how we use, partnership payments and healthcare special payments to fund the health system, which is effectively the responsibility primarily of the states in the public area, but the states are simply not adequately funded to do it. So a courageous government would have stepped in and fixed up that problem. They would have looked at that vertical fiscal inequity and said that a component of taxation should be automatically given to state governments. And I challenge this side of the chamber again to tell me why, if you're operating in a state government, you're simply incapable of providing these health services. Because all of our states are big enough, smart enough, hairy enough and ugly enough to be able to run community health and to be able to run a hospital. I mean, you don't leave this chamber, Deputy Speaker, and go and join a state legislature and suddenly have no compassion or care or ability to run a health system. They're just like us. The states are just like us. They can do it if you give them the means, but they simply don't. They don't have the means because they don't have the funding, the increase in healthcare costs, the healthcare index, which is a combination of a technology index, a population, a hospital utilisation factor, and of course health inflation, and a product of those 3. It's simply a 10% per year increase can't keep up with GST takings of 6%. Well, why don't we just fix that and cover the 4% out of federal revenue? It would have been far simpler. To the other side of the chamber, I say this. It's seductive and it's attractive to build massive nationwide networks of bureaucrats. But in the end, the question that you have not answered is why can't it be done locally, reporting in to effectively a national partnership with priorities. Those priorities are clear. How we can fix it is clear. We need an Auditor General in Health that actually examines the role and the performance of our health providers. And it shouldn't have the state government membership on it. Whoever is providing the health should not also be writing the monitoring and evaluation plans and then filtering the reports. We need to have a system where we engage the private sector. We need a system where we remove those massive fiscal schisms that run through the health system. But they, Deputy Speaker, were all too hard. And so today, instead, we debate a pea and shell game of moving money from one jurisdiction to another and then handing it right back and calling it a breakthrough in health.
Order. The honourable member's time has expired.